Thank you, Mrs. Chairman. Thank you, Mr. Chairman. Dear colleagues, I'm very honored to be here. I'm the first time in this Omics International Conferences, and I am glad that I can be here and share experience in the field of gastroenterology with colleagues all over the world. My topic for the keynote today is IBD. Why IBD? Probably because in the Eastern Europe and in my country there is an increased incidence of this disease. We have to face with an increasing number of cases in the last years, and I think it is subject of interest not only in my geographical area but all over the world. I am a clinician and an endoscopist, so my topics will be generally, and I think that I'm glad that there are other colleagues involved, like Mrs. Chairman and other colleagues involved in the research of the disease, so we can share experience and get new information. Oh, sorry, this one. As term and definitions, we know that we talk now today about two main forms in inflammatory bowel disease. The one, ulcerative colitis, is a condition, continuous mucosal inflammation of the colon and affecting the rectum and variable extent of the colon in continuity. The second important form is the Crohn's disease, a lifelong disease that encompasses a multi-system group of disorders and with asymmetric transmural and occasionally granulomatous inflammation affecting all the gastrointestinal tract. We have also the forms that we can say, and we can make the distinction between ulcerative colitis or Crohn's disease called IBD unclassified, and we also have now in the literature the term of indeterminate colitis. Nowadays, a term reserved for pathologists to describe colectomy attachment which has overlapping features of ulcerative colitis and Crohn's disease. All of us, we know the situation and the progression of the IBD, of course, for the Crohn's disease also in any part of gastrointestinal tract. As demographics, we know that the prevalence and incidence are highest in Europe and North America. Recent studies showed an increase in Asia and especially in China. And we know that peak incidence patients between ages 15 and 30 years. Unfortunately, in our days, the etiology and pathogenesis is not very well understood. We know that there are some hypotheses. The genetic predisposition and susceptibility is very well documented in the both ulcerative colitis and Crohn's disease. It is also known that there is an altered, dysregulated immune response, and that immune response disrupts the intestinal mucosa and leads to a chronic inflammatory process. Of course, there are involved many cytokines, and there is also involved the cellular immune system that participate in the pathogenesis of this disease, and the research for finding a very good therapeutic mean is now concerning many of these pathways. And the third hypothesis, an altered response to the gut microorganism. The environmental factors are also studied. Even the studies are inconsistent. It is known that smoking increases the risk of Crohn's disease, and current smoking protects against ulcerative colitis. And there are also involved in some studies the dietary factors, like high fiber intake and high intake of fruits, vegetables appear to be protective for IBD, and the high animal protein intake carries high risk of IBD. About the genes, there are many researches in Crohn's disease and in ulcerative colitis, and there are many genes described for this. Most of the genes are involved in the signal transduction in immune function, and also there are some involved in the autophagosome pathway that processes intracellular bacteria. There are also evidence about the genes in ulcerative colitis, but the genetic predisposition appears to be lesser in magnitude than for Crohn's disease, but consists of a set of genetic susceptibilities that show significant overlap with Crohn's disease. The interferon gamma interleukin 26-22 genes play roles in the immune response to pathogens as well as in tissue inflammation process. What about the diagnosis? I'm working in Europe, and for us now there are the statements for the echo statements. There is very well known that there is not a single gold standard for the diagnosis, even in Crohn's disease or in ulcerative colitis. Of course, we have some steps which include clinics, endoscopy, histology, imagistic means, and some lab tests, including biochemistry. Concerning the clinic in Crohn's disease, most of our patients are coming to us with chronic diarrhea. Usually is a diarrhea more than 6 weeks, and this one is maybe adequate to difference for the self-limited infectious diarrhea. In high percentage of person, there is abdominal pain and weight loss before diagnosis. Blood and mucus in the stool may be seen in patients with Crohn's disease, but less frequently than in patients with ulcerative colitis. And of course, there are the well-known extraintestinal manifestation of the gastrointestinal symptoms. The perianal fistula are more characteristic and present in more than 10% of our patients. About the clinic in ulcerative colitis, the chronic diarrhea is almost invariably associated with rectal bleeding, or at least visible blood in the stools. There are more specific symptoms like rectal urgencies, tenesmus, passage of mucopurulent exudates, nocturnal defecation, and crampy abdominal pain, which are most specific for ulcerative colitis. We can find anal or perianal lesions, but which are minor and may complicate severe diarrhea. And of course, systemic symptoms, including weight loss, fever, tachycardia, or extraintestinal manifestation, especially arthropathy, episcleritis, erythema nodosus, which may accompany the presentation in some of the patients. As a second step for diagnosis, the IBD endoscopy is now today one of the important means. is fundamental to care the patient and, with IBD, and is essential for diagnosing and treating both Crohn's disease and ulcerative colitis. Is used today to make an initial diagnosis, to distinguish the two forms, the Crohn's disease or ulcerative colitis. We use endoscopy to assess disease extent and activity. Is very helpful for us to monitor the therapy, and this, of course, the survey of dysplasia. And with the new techniques of endoscopics, sometimes we can have also therapeutic means like dilation of stenotic strictures, especially in Crohn's disease. There are well-known classifications for both two forms. For ulcerative colitis, there is the revised Montreal classification that we use in our practice, including the definition and maximal endoscopic involvement for proctitis, like left-sided or extensive in ulcerative colitis, and for Crohn's disease, with the three categories of the factors that we take into account, which one is the age, the location, and behavior, and these are very important to give us the form of the IBD and also information for the treatment. What is today very interesting is the fact that in many studies and many countries it was tried to find IBD scores that can be generally used. But until now, there are some validated scores for clinical trials and for studies like those for endoscopic for Crohn's disease. But what is very well known that there is no endoscopic score until now which can validate the definition of the mucosal healing, one of the targets in the treatment of inflammatory bowel diseases today. As new techniques of endoscopy have led to improved observation of the mucosal details, is this important to reduce to the random biopsies and to targeted biopsies for histologic examination. Some of the new equipments like probe-based or scope-based confocal laser techniques or endocytoscopy, which are top endoscopic techniques, are available only in specialized academic centers. But for the daily practice, it is said today that high definition endoscopy has become a standard and is widely used in clinical practice. In addition, specialized training and adequate clinic experience are necessary to perform these novel endoscopies. And these techniques are so far from being used as the gold standard in IBD, and some studies have been also controversial for this. Thus, it requires more experience before implementing them in clinical practice. There is a chart here with endoscopic techniques available, going from the white light endoscopy to other emerging endoscopic techniques. I want to mention the molecular imaging possible today in endoscopy, and which can probably in the future give more and more accurate information. Regarding the histology, we know that there are some features characteristic for Crohn's disease, like focal discontinuous chronic inflammation and patchy chronic inflammation, the discontinuous crypt distortion and granulomas. that are generally accepted as microscopic features for diagnosis of Crohn's disease. And additional techniques now, like flow cytometry, immunohistochemistry, and some markers can be helpful for diagnosis the intraepithelial neoplasia, and the recognition of dysplasia and surveillance of this is now the most important for the management of cancer risk, both in Crohn's disease and ulcerative colitis. Here are the echo statements for the histology in Crohn's disease, and they are the same as those proposed for ulcerative colitis, and a second opinion usually is recommended for diagnosis. Regarding the histology in ulcerative colitis, the main abnormalities are the architectural features, including crypt branching, crypt distortion, crypt atrophy, also with epithelial cell abnormalities like mucin depletion and Panna cell metaplasia, and the inflammatory features, of course, because it's an inflammatory bowel disease with basal plasmacytosis, basal lymphoid aggregates, and lamina propria eosinophils. The echo statements are also well-established histology for ulcerative colitis, and regarding the imaging in inflammatory bowel disease, going from the basis, we need sometimes imaging techniques for especially for managing and for diagnosing and managing the complications, going from the usual one like enteroclysis, but today ultrasound is a very help, and computer tomography, MRI, or scintigraphy and PET-CT are used depending on the center and on the experience of the center. A meta-analysis of prospective studies in these techniques show for MRI very good specificity and a sensitivity, but we can see also that ultrasound, which is a more cheaper technique with a good experience of could be with very good sensitivity and specificity for detecting the disease and some complications. For the possible diagnosis approaches of evaluation of the small bowel and complications, there are some steps, and these steps are used depending on the experience in different centers, going for the ultrasound to MRI, CT, capsule endoscopy, or enteroscopy. And also is the same for the ulcerative colitis, combining the imaging techniques with the endoscopic techniques. Regarding the blood chemistry, unfortunately we don't have until now a very one and special marker for diagnosing and following up the IBDs. But the C-reactive protein and fecal calprotein may be best used as screening tool to decide the timing or endoscopic or cross-sectional imaging reassessment. Still, the reliability of these markers to predict mucosal healing is not fully established, and most of the study showed us that the combination of fecal calprotein at a threshold of 250 and C-reactive protein has shown to improve the ability to predict mucosal healing with a sensitivity and specificity of about 70%. Regarding the treatment, the goal for our patients, traditionally the goals of pharmacological or biological treatment have been the two steps. One, the reduction of inflammatory process during relapses, and then extending the period in which the patient is maintained in remission for clinical symptoms. Hence, IBD treatment depends on the balance between efficacy and secondary side effects of the drugs used, and in addition to patient's response to prior therapy. What should we choose? The choice of the therapy should be based on the frequency of the disease relapse, the extent and severity of disease, and the presence of extraintestinal manifestation, which can indicate serious complications. There is a chart here with evolution and with the natural evolution of the disease. Of course, the natural course going during the years with increased number of disease complication. The goals from the beginning were to induce and maintain the gastrointestinal healing. Then it was a step to prevent need for steroids, and prevent stricture and penetrating complications, to prevent extraintestinal complications, to decrease hospitalization or surgery, and not in the last, to decrease the long-term cost of care. We have a chart here summarizing the therapy available up to today in inflammatory bowel disease. We know that there is a classical treatment including mesalamine. There are the antibiotics, there are the immunomodulators, the steroids, of course, and in the last year, most of the PrEPs of anti-TNF, anti-integrins. Unfortunately, we cannot always cure our patients with some of these available therapeutic drugs, and in this case, and most of these cases, surgery will be the therapeutic option. As new points in inflammatory bowel disease, in Crohn's disease, due to progressive evolution to irreversible bowel damage, now the Lemon Index, the Crohn's disease digestive tract damage score, it was in the literature first tool that aims to measure the cumulative structural bowel damage, including strictures, penetrating lesions, and surgical rejection. And the future potential application for this index could be the assessment of disease progression and patient heterogeneity, identification of parameters associated with high risk of rapid progression, and showing the impact of therapy strategies on long-term outcomes. The second emerging endpoint is disability, as an objective which is more and more taking into account today in the management of IBD patients, as an objective of measuring the impairments, activity limitations, and participation restrictions that are experienced by our patients with IBD. And hopefully in the years to come, it is likely that predictors to bowel damage and disability will be identified, as well as the impact of new drugs and therapeutic strategies in preventing them. There are two major approaches in the treatment of the patients with IBD. The one is the so-called step-up therapy. The other one is well-known top-down therapy. However, the choice of one by the physician depends on the patient's responsiveness to the prior therapies, clinical conditions, and diagnosis. As pharmacological therapies in most of the cases It just started with conventional therapies. We know today the 5 distinct pharmacological classes. The aminosalicylates, the modulators of intestinal microbiota, corticosteroids, dioperins, and acid folic antagonist. And of course, in the last years, the newer options, biologics. I try to summarize in this slide the options up to date in the treatment of IBD. There are here the conventional strategies and therapies, and the 2 major categories in which there are many studies and clinical trials, and trying to find the best solution for the IBD treatment is in the field of biological therapy and in the field of cellular therapy. The biologics, we know that are so termed because of their protein origin. The TNF-specific monoclonal antibodies were developed as new treatment alternative, and after almost more of the guidelines, including the ECHO guidelines, they should be used in case of unresponsiveness or contraindications to other treatments discussed above. They are highly effective, as many studies show, for treatment of moderate to severe disease. Primarily is induction and maintenance therapy. There are different anti-TNF antibodies available, such infliximab, adalimumab, certolizumab, and so on. And it is important to stress the possibility of formation of antibodies against anti-TNF agents, and some secondary and important side effects that in some patients limited the treatment with these special molecules. The novel directions in biological therapy includes the therapy directed at modulation of the genus kinase signal transducer pathway with a number of downstream cytokine receptors, and which can represent a promising treatment. And in this context, the tofacitinib, an orally administered drug, has shown encouraging results, especially for UC treatment. Regarding another research field in the therapy of IBD, the cellular therapy for IBD, this is based on the characteristic of stem cells to self-renew and regenerate tissues together with their immune modulatory potential. And this was investigated as an alternative therapy for IBD. There are some important directions in this field. One is the HCCT, autologous hematopoietic stem cell transplantation, that was used to treat IBD in both experimental and human studies. Also, the protocols using mesenchymal stem cells, which are able to inhibit the Th17 cell differentiation and function, were used in experimental IBD studies, also in animal and humans. And experimental models have also shown that several types of tolerogenic or regulatory dendritic cells can also ameliorate inflammatory bowel disease. In conclusion, we can say that IBD is a lifelong disease arising from an interaction between genetic and environmental factors, observed predominantly in the developed countries of the world. The precise etiology and pathogenesis is unknown, and therefore medical therapy to cure the disease is not yet available. A single gold standard for diagnosis is not available, so we use combination of clinical evaluation, endoscopy, radiological and or biological investigation. would have to mention that remarkable developments in the endoscopic technologies provide more sensitive assessment of disease activity, prognosis, response to therapy, or may facilitate initial endoscopic therapies like dilatation of bowel strictures in Crohn's disease. And there is a need for using an international valid histologic index for complete mucosal healing, including in not only in the clinical trials but in the daily practice. Regarding the treatment in IBD, the treat-to-target strategy based on frequent assessment of disease may modify the natural course of the disease and could be one of the best options today. The treatment that combines immunosuppressors, biological therapy, and modulator of intestinal microbiota without leading to exacerbated immunosuppression with minimal adverse effects and reduced or absent bacterial translocation, infection-related complications, or progression to cancer would be of major importance. The cellular therapy may be an alternative to conventional treatments in the next future, and of course further studies are necessary and should be conducted to develop novel therapies. Not in the end, our goal is to make our patients well and keep them well. And for this, we have to climb all the steps of the pyramid, going from endoscopic healing to histologic healing, ultrastructural healing, and finally to obtain the most important goal, the functional healing and well-being of our patients. Thank you.
Thank you very much.
Sorry.
This was a very nice overview on IBD, where we are today. So are there any questions from the floor? Professor, you had a question?
Thank you for this very nice talk. Can you tell me there is an indication not to treat this patient? When you give treatment to irritable bowel syndrome?
To give
some cases
not to treat
not
the
to treat.
patients
You know?
with IBD.
Yes. You know, or
there is this depends on the form of the patients.
yes, you told
There
us,
are-
you told the audience this.
There are, as I said before, of course, the treatment is depending on the form of the IBD, going from mild forms to moderate or severe forms of IBD. In some cases, as I said, for example, there is a contraindication to treat, for example, with biologics, in the cases that there are side effects of the therapy, like the activation of tuberculosis in these patients. And in these patients, we have to stop the treatment with these biologics, and we have to treat the tuberculosis and to wait until we can reintroduce the treatment.
Also, if the symptoms is mild, you wait and see.
Yes, we
Yes,
we
of
wait
course.
and see, of course, in the mild symptoms, of course.
There's
Yes.
one question.
Thank you for the nice talk. And you mentioned about Crohn's disease is associated with colon cancer. Is that what's the? I know the.
Not associated. Not
It's not
associated.
associated.
I
Maybe.
mentioned that
Yeah.
in Crohn's disease and ulcerative colitis,
Yeah.
we have to follow up the patients with dysplasia, because dysplasia is one of the common features that we can find it in these patients, and we know that there is an increased risk to develop colonic cancer in these patients with IBD. This is why we have to follow up these patients with several biopsies and targeted biopsies to find the right moment when there is the translation from the dysplasia to neoplasia in these long-standing forms of IBD.
Okay, thank you. Can I ask the second one question? Yeah. And so for the treatment of, the Crohn's disease can be manifested by the symptoms outside of the intestine.
Yes,
so
extraintestinal manifestations.
Is the treatment similar to?
Yes.
Yeah, okay.
Yes,
so
the treatment includes the main disease with the inflammatory bowel disease. We had many patients, for example, that we have them with arthritis or erythema nodosus. There are patients with ulcerative colitis, which are on the treatment with adalimumab, an anti-TNF therapy, and they after the treatment they disappear, the erythema nodosus and the arthritis, during the progressive healing of the mucosa. So this manifestation can be cured with the basic therapy.
Thank you.
Thank you for a nice presentation. So I just wanted to add few points for your presentation. In Crohn's disease, actually there will be transmural inflammation.
Yes.
So the inflammation there is ulceration of the lining epithelium, that is the mucosa. The inflammation will enter into the submucosa, then into the muscular layer. So that is the transmural inflammation. Once it enters into the transmural inflammation, then later stages, as it progresses further, it will go for that stricture formation, because that inflammation has to heal. It will go for stricture formation, then skip lesions, all those things are seen. Initial phases of Crohn's disease is very difficult for diagnosis on histopathology, because there will be inflammation. We cannot differentiate different types of inflammation, whether it is ulcerative colitis or Crohn's disease. It's very difficult to differentiate. Ulcerative colitis is above the muscular layer. It will never enter into the muscle layer. It is very superficial, whereas Crohn's disease, it will enter inside. Here we have to identify the risk factor rather than risk factors. Earlier it was saying that stress factor is mainly responsible for ulcerative colitis or any type of inflammatory bowel disease. But now maybe because of some virus or bacteria which has reacted, that might cause, that's an information which has been provided now. It is not clear. Any idea about providing any antioxidants to the patient? Because why I'm just trying to tell this one is, for any inflammatory process which occurs in the intestine.
What are you referring at?
Antioxidants.
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 As therapy for this or what?
Along with your regular therapy, can antioxidants be provided? Supportive.
Like what? You refer like what? For
vitamins or something like that. Vitamin A, E, all are antioxidants.
So
supportive therapy.
There are many studies and many trials that try to find options and new options in the treatment of this, but they are not validated until now in so extensive studies to be included in the guidelines for therapies.
Okay. Because in routine pathogenesis, what we usually tell is, when inflammation starts in that picture, the cells will lyse, and that is, they will die due to the release of more number of inflammatory cytokines, and they will in turn cause increase in the
yes,
oxidants.
But this is the challenge in the treatment, because it was not identified only one cytokine, or there is no identified only one cascade of inflammatory cytokines that are involved here. And some of the drugs are targeted on one of these, or like tofacitinib in several, but not in the all. And this, I think that more research is needed to find exactly pathogenesis and then to find the exactly therapeutic agent.
I have one question for you as a researcher to a
Of
medical
course,
doctor.
you are more involved in the research. I'm a clinician.
So we need each other, eh? I mean, that is,
Yeah, of
that is
course.
obvious. But so we have invested tremendous amounts of energy, money into genome scanning our patients. What do you, as a medical doctor, think we have gained from that? Did we gain something from that, in fact?
I think the genetic is very important and is very highly involved, not only in the appearance of the inflammatory bowel disease and cancer, but also in several other diseases. And my hope is that in the future, knowing very good the genomic can provide us another therapeutic tool like genetic therapy or something else that could help in more of the cases with inflammatory bowel disease. So I think the genetic research is one of the most important.
That's good to know. Thank you.
Thank you.
Hello. Yes. In relation to the treatment and the healing, what is the? How do you consider in the patient there's a healing process going on after the treatment at the histologic level, according to your cartoon, or endoscopic healing? What is the criteria to say that there's a healing of the mucosa after the treatment? Because there's a lot of controversy also in that.
Thank you for the question. There are many controversies in the treatment and the observing the healing in inflammatory bowel disease. Until several years ago, the goal was, so first in the beginning was the clinical remission, was an important goal, not only for the studies, but also for the patients. Then it was another period that said that the endoscopic resolution of the disease, so it was very important. But it was shown that many cases relapsed. So then it was the next step that said the histological healing is the one that we have to achieve. And more studies now showed that there is not enough. The ultrastructural healing and the functional healing would be the end point of the therapy for these patients.